Good afternoon, everyone. My name is Helge Gilja. I have to apologize for my bad voice because right now COVID-19 is running through my body, but hopefully I will be able to endure through the whole presentation. So my task is to demonstrate the great capabilities of ultrasound using various modes and methods in the field of hepatology and liver diseases. And I want to present clinical scenarios where ultrasound often performs better than even CT and MRI. And I hope to show you that ultrasound may represent a one-stop shopping to the best of your patients with liver diseases. This video illustrates nicely the great capacity of ultrasound because it has high temporal and high spatial resolution, and within seconds you can see how many lesions of the liver in these patients with hepatic adenomatosis is behaving. I will point to all these tools we have in our wonderful ultrasound toolbox, not only B mode, but we can also use B flow, Doppler, color Doppler, pulse Doppler, elastography, both with strain imaging and shear wave imaging, and we can add on contrast enhanced ultrasound as well. Furthermore, there are other options that I will not touch upon in this lecture: liver biopsy, ablation techniques, and even sonoporation therapy, which is beyond this topic of this lecture. In many cases, ultrasound is better than CT, as always also shown in the previous lecture, and in particularly regarding the liver. It's true for small and complex cysts. It's true when you want to do detailed flow evaluation in real time, for instance, in portal vein thrombosis or in Budd-Chiari disease. And it holds true for evaluation of cirrhosis, which is a very common problem in our daily clinical practice. You can do very nice global liver assessment using B mode and Doppler and study portal hypertension in detail. And also I will show you examples of the TIPS maneuver. To start with a simple challenge, often CT is not able to exactly pinpoint what is a small cyst of the liver. I get many patients referred for ultrasound just to clarify whether the small lesions are cysts or not. And even on ordinary B mode, it's usually quite easy to depict a cyst from another solid lesion. As you can see here, there are many examples of that. This was a patient with lots of different lesions in the liver, some cysts, some solid lesions, and in these cases, often also ultrasound performs very well. So when you are in doubt, you can sound it out using ultrasound, B mode, Doppler, contrast agents, and so forth. In this case, we performed CUS examination, and we were looking at this patient, one of the solid lesions. And as you can see here, these lesions, two lesions here, they are hyper-enhancing in the arterial phase, indicating that these are not complex cysts, these are solid lesions of other nature. And when we look at the late phase in the same patient, we can see that there is clear washout of these lesions, indicating that these are malignant and need a different therapy than cysts alone. Regarding complex large cyst evaluation, in this paper by Wong and co-workers recently published in AGR, they showed very nicely that these complex cysts was difficult to analyze properly with CT alone, but when you performed a contrast and ultrasound, the authors were able to show that the lesions were completely avascular, confirming the diagnosis of a non-neoplastic complicated cyst, as shown here. So yet another case where ultrasound outperforms CT. When it comes to flow evaluation, and particularly flow with slow velocities, ultrasound also have a great advantage compared to CT because you can image and visualize very low velocities. For instance, in portal vein thrombosis. As you see here in B mode, you suspect something inside the portal vein, and that is confirmed with color Doppler, where the mass of the vein is outlined nicely. Furthermore, of course, the real-time capacity of ultrasound really outperforms CT when you can see how detailed this benign thrombus is depicted using real-time Doppler. But sometimes life is more difficult, like if this patient, a 59-year-old man with HCV and a compensated cirrhosis, we detected 2 lesions here, one solid lesion here, and one lesion inside a dilated portal vein. And the big question is this thrombus inside the vein a benign or malignant thrombus? To answer that, we inject contrast. Here is the primary tumor. Here is the clot inside the vein. And in early arterial phase, we see a typical arterial pattern in cirrhotic liver with a hyper-enhancing tumor, but also hyper-enhancing clot inside the portal vein, indicating that this is viable tissue, malignant tissue. And the final proof we can get when we look at the late phase after 3.40 seconds, we can see that there is washout in the primary tumor, but we can also see washout of the thrombus. And these are very important findings in order to determine the right indication for transplantation or not in such a patient. Budd-Chiari syndrome is a fairly rare disease of the liver, which is constituted by abdominal pain, typically ascites, and liver failure. And this is caused by thrombosis in one or more of the hepatic veins. And this is a typical finding, lots of ascites, a straight, regular capsule of the liver. And if you look very carefully at this liver, you can't actually see any hepatic veins. So in these cases, of course, we apply Doppler. And in color Doppler, you can see there are some flow in the cava vein. And you can also appreciate there is flow in the portal vein. However, you are not able to see any flow in the hepatic veins, indicating strongly that this is a patient with Budd-Chiari, and that was the case, and she could undergo proper therapy. Let's then move to the elevation of cirrhotic livers. This is really an increasing problem worldwide, and by using ultrasound, you can do a lot of good for your patients. The points made in green means that you can do this evaluation with fairly cheap equipment without any Doppler, actually, only B mode. In yellow, you have more advanced options with more advanced, more expensive scanners. And finally, you can do proper invasive procedures as well, if necessary. But you can easily evaluate the size of the liver, the size of the left lobe and the lobus caudatus. You can look at the smoothness of the capsula. You can look at the ascites, and you can do fine evaluation of echogenicity, homogeneity of the tissue, nodularity, and focal lesions. Moreover, you can also look at the bile ducts and gallbladder and measure the diameter of portal vein or even splenic vein and the spleen size. All these can be performed with B mode only. But then you can add more advanced techniques with color Doppler, pulse Doppler, elastography, and CUS even, to do more advanced evaluation of your patient. So just some example of classical liver cirrhosis, ascites, a coarse liver with an irregular surface. And here you can see the dearrangement of the normal tissue with lots of fibers going into the liver parenchyma. The liver capsula is important, and I recommend to use high frequency, preferably 9 to 12 megahertz, in order to evaluate that properly. Here, in a healthy case, a smooth capsula, but as soon as the cirrhosis develops, you get a very irregular border, And when ascites appears, you can see the irregularity even more clearly, also with nodularity inside the liver. The lobus caudatus tend to expand in size when you get cirrhosis. And here you can see a classical finding. The segment number 1 is behind the left lobe of the liver here. And when that exceeds approximately 3.5 centimeters, that indicates hypertrophy and pathology. Portal hypertension can easily be evaluated with Doppler ultrasound. And there are many criteria that you can actually look upon with ultrasound. The dilated portal vein is important, above 13 millimeters. Decreased velocity in the portal vein below 13 centimeters per second. So you can recall the number 13 is important here. Then you can also depict reverse flow in the portal vein, dilated splenic vein. You can image shunting in the splenic hilum, and you can even have recanalization of the umbilical vein, and an enlarged spleen can easily be detected with ultrasound. Esophageal varices is also something you can actually explore with transabdominal ultrasound. This image shows recanalization of the umbilical vein, which is a marker of portal hypertension. The portal vein is nicely imaged usually here from the epigastric surface, just anterior to the cava vein. And when you look in the intercostal space from the right flank, you can nicely measure also the velocity of the portal vein here. And in this case, it is normal, around 20 centimeters per second. Dilated splenic vein in portal hypertension is also a critical finding. You can see it here nicely in the hilum of the spleen. And here you can also see some shunting. And splenic shunts is easily depicted with color Doppler going down to the renal area. You can also even detect esophageal varices using transabdominal ultrasound. And in this patient I had a few years ago, I used the left lobe of the liver as an acoustic window to look back to visualize the esophagus. And these hollows here indicated that there could be some dilated veins. And just by putting on the color Doppler, we can easily appreciate that there are huge varices around the esophagus and even down into the gastric area in this patient. And if you perform such an examination, you're actually able to save lives, because a patient like this, you have to immediately refer to upper endoscopy with band ligation. Furthermore, in order to relieve the hypertension in the portal area, in some cases, we put in a transjugular intrahepatic portosystemic shunt. And these shunts can easily be evaluated also using ultrasound Doppler. Here is one example in B mode, and here is with color Doppler to show that there is flow inside. The most important indication is intractable variceal bleeding and non-responding ascites. We can evaluate tips after the placement, just recently after the placement, and in a follow-up course over years. And typically, just after this has been inserted, the flow is very high, often above 100 centimeters per second. But as times evolves, the speed, the velocity of the portal vein gets lower. And you can easily, by doing real-time Doppler evaluation like this, see the persistence of the tips. However, in a few cases, we are unfortunate and the tips is clotted, and that is something you can easily diagnose also by using color Doppler, like in this case. So let's move on to other tools in our ultrasound toolbox. We move now to elastography. And the most used method these days for evaluating the liver tissue and fibrosis is what we call shear wave imaging, shear wave elastography. When we do ordinary B-mode imaging, we use the ultrasound wave that's going perpendicular down, longitudinal waves into the depth, and these waves are reflected and we create an image. And the speed of sound here is very high, 1540 meters per second, typically in tissue. However, also shear waves are generated, which are directly 90 degrees on the longitudinal waves. And these shear waves, we are able also now to detect with our scanner, calculating the speed of the shear wave, which is much lower than the speed of the longitudinal waves. Typically, these are 1 to 10 meters per second in tissue, and the higher speed they have, the stiffer is the tissue. And the nice thing is that the speed of sound in these shear waves are correlated to the degree of fibrosis in the liver. So here we have measurements from a healthy tissue here and further down to a cirrhotic liver with a lot of fibrotic tissue scarring in the liver parenchyma. We have in the European Federation of Ultrasound given out several guidelines, and the last one on the liver was in 2017, where we had 29 recommendations of how to perform and how to use elastography for chronic liver diseases. And one of the important recommendations that were given for hepatitis C and B is that if you use 2D shear wave elastography, you can, as first-line assessment for the severity of liver fibrosis, use that in patients with chronic viral hepatitis C, and it performs best with regard to ruling out of cirrhosis. Furthermore, also in chronic hepatitis B, you can use elastography to identify those with cirrhosis. Both these recommendations have very broad consensus among the experts. So when you apply ultrasound elastography in your patients, in addition to B-mode and Doppler, you do a good job for your patient. It correlates well with histology regarding fibrosis. It's easy to perform. It prolongs the ultrasound examination with only a couple of minutes, and it provides really valuable information to the clinician. If you compare to CT, that will not give data on liver stiffness. MR is capable of that, but that method has low availability worldwide. It's expensive and very time-consuming as well. So let's move on with the other tools in our toolbox, and we have now come to contrast-enhanced ultrasound. I've already given some examples, and the nice thing about this is that the most frequent solid lesions of the liver can be accurately characterized by contrast-enhanced ultrasound without further need of CT and MRI. However, there are some exceptions of this, but the main benign disorders like hemangioma and FNH, focal nodular hyperplasia, and also adenoma, which I show an example of here. This is one case of adenoma. The kidney is here, the adenoma is here, and you can see very rapid early enhancement with a artery coming in, a subcapsular artery, and enhancement long before the rest of the parenchyma here. And this patient had no washout in late phase, classical hepatic adenoma. Also, malignant diseases can be detected. The most frequent one is metastasis. And HCC, hepatocellular carcinoma, is one exception of the rule that I would like to come back to also. We have just released new guidelines. WFUMB has collaborated with all the other federations around the world to promote contrast-enhanced ultrasound, and I recommend strongly to read these guidelines that is just being published. As you may know, there are three phases in liver perfusion. We have the arterial phase, that lasts up to 30 seconds. We have the portal phase from half a minute to 2 minutes, and we have the sinusoidal phase or late phase from 2 to 4 minutes. However, if you apply SonaSuede in your contrast-enhanced study, you also have an added-on post-vascular phase or cup-for-cell phase that lasts from 4 to 30 minutes. And this image shows one case of liver metastasis after 14 minutes after contrast injection. And you can see how all the metastases are really making Swiss cheese out of this liver. And you can also appreciate that some of the metastases have an increased vascular surrounding, indicating increased activity and vascularity. I have got many referrals from the CT lab regarding unclear findings on CT. And this was a patient where this was the finding, and we injected contrast to see if there was any typical pattern. This is the Doppler pattern. There is just a tiny signal in the periphery of the tumor. When we inject contrast, we can see a classical typical appearance, peripheral globular enhancement with no central filling in the arterial phase. Later, this tumor showed slow centripetal filling. All these are classical criteria of hemangioma. And if you observe something like this, you don't need to do any more imaging studies, and you don't need to take any biopsies. Focal nodular hyperplasia is another fairly prevalent disorder of the liver. And typically, they have a centrifugal stellate branching in early arterial phase. They have a spoke wheel pattern in approximate 40%, and some has also scarring. They have a typically intense homogeneous uptake, and iso or hyperechogenic lesions are seen in portal and late phase. So if you have all these characteristic features, the sensitivity and specificity of using CUS is very, very good. Here we have a case of FNH. The tumor is here. And if you look carefully, you can see a very rapid enhancement here. Also another smaller tumor here. And with the high temporal and spatial resolution of ultrasound, this diagnosis is usually quite easy to make. And be aware, this is after 12 seconds. You only see the center of the tumor, but within a couple of seconds, the whole tumor is enhanced, and 2 seconds later, the whole tumor is enhanced and hyperperfused, giving rise to the diagnosis when there is no washout in late phase. And with a temporal resolution like this, ultrasound far outperforms both CT and MRI. No other imaging modality can do this with this very detailed speed and spatial resolution. Let's move to detection of other focal liver lesions. This is a 3D acquisition of metastasis to the liver. And in this patient, we inject contrast to evaluate the lesion here. And you can see this lesion is hyperenhancing clearly in the arterial phase. But what I really want to point out is the rapid washout. After 20 seconds only, the tumor is starting to wash out. And this is a classical criteria of a metastasis to the liver. An HCC would not behave like this in comparison. Another classical finding of liver metastasis is that in late phase, as here, the temporal and spatial resolution again makes it possible to detect tiny, small metastases to the liver, which is hard to see on any CT or MR examination. So if you suspect metastasis to the liver, contrast injection is a very efficient method to detect it and also to rule it out in some cases. And here is one case where we use SonaSuede, and we study in the late Kupfer phase, post-vascular phase, and we use a 9 megahertz linear array, and you can see the very nice resolution and how these metastases are affecting the liver parenchyma. So let's turn to HCC, which is one of the great imitators in medicine. It's a difficult to diagnose to make, so therefore we have to use more than one method. So this is the one case I would show today that actually require more than one imaging method. Regarding criteria, we have the Barcelona criteria. We have 2 independent imaging methods are needed to avoid a biopsy. And then you can proceed to other surgical methods or even transplantation. There is a big problem today, increasing incidence worldwide. Hepatocellular carcinoma, in 90% they have known etiology. We also know that alpha-fetoprotein has a limited sensitivity, only 60% approximately. And the most frequent one is alcohol and HCV. We also know that NASH is an increasing incidence in medicine, and thus further feeding the growth in HCC prevalence. So HCC constitutes a big clinical problem, and it's hard to detect. Particularly in patients with cirrhosis, you need to be aware that if you detect a new lesion, you should always suspect a HCC, particularly if the lesion is hyperenhancing with contrast-enhanced ultrasound. In this case, we have a cirrhotic liver, we have an isoechogenic tumor here, and we want to, of course, establish whether this is a malignant tumor or not. If we look at this patient with Doppler, you can see the classical basket phenomena around the tumor. And then we inject the contrast, we see the tumor here. And the big question is this tumor hypervascular or not? That is the main criteria. And as you can see quite nicely, this tumor is hyperenhancing in the arterial phase, thus proving that it is most likely an HCC. And even if it doesn't wash out properly, it still might be an HCC. Here, after 4 minutes in late phase, we can see that the tumor is barely washing out, but still the most important criteria is hyperenhancement in the arterial phase, thus meaning that this was an HCC that was also confirmed later. Just one example also from MRI showing that in this publication from Wang and co-workers from 2020, MRI was not able to detect hyperenhancing in the arterial phase. However, contrast and ultrasound clearly and demonstratively showed that this tumor was hyperenhancing, giving the rise to the diagnosis of HCC. So to conclude, if you want to see the difference between FNH and HCC, bear in mind this simple allegory. FNH behaves like a firework sprouting out from a central position in a centrifugal fashion. Opposite to this, an HCC behaves like a lightning stroke from outside of the tumor with a feeding artery, which paves its way from the periphery of the tumor into the center of the tumor in a centripetal fashion. So, in conclusion, ultrasound may enable you as doctor to do a one-stop shopping for your patients. When you use all the tools in the toolbox, ultrasound B mode, Doppler with color and pulse Doppler, elastography, contrast and ultrasound, and you can also add on biopsy, you are able to really make good for your patient. And both color Doppler and the CUS technique makes you do a very rapid and efficient diagnosis for your patients. From vision to decision denotes the rapid transition from ultrasound diagnosis to clinical decision-making that you can do to the best of patient management. Ultrasound gives you, as doctor, the sharp vision similar to the lammergeier, which is depicted here, that uses its extremely sharp vision to find its prey and get food. By using ultrasound, you can release the full potential of being an efficient doctor, providing a one-stop shopping for your patients with liver diseases. Thank you very much for your attention.